my name is Dr. Chandani Patel, and my scoping review is on maxillary growth in cleft lip and palate children treated with secondary alveolar bone grafting, a scoping review. So to get started, I'm just going to go into the epidemiology and etiology. Orofacial clefts are the most common craniofacial birth defects in humans worldwide, occurring more frequently in Asian countries in comparison to American and African countries. According to the CDC, the prevalence of cleft lip and cleft palate in the United States is 1 per 1,600 births. Cleft lip without cleft palate is 1 in every 2,800 births, and cleft palate only is 1 in 1,700 births. Orofacial clefts can be further categorized as syndromic if the cleft occurs in addition to other developmental or structural malformations, or non-syndromic if the cleft occurs independently. These orofacial clefts are classified based also on the phenotypic presentation, so a cleft lip can present in isolation unilaterally or bilaterally. It can extend into the alveolus, which would classify it as a cleft lip and alveolus. Palatal clefts occur to one side or on both sides of the midline of the hard palate. They're associated with or without cleft lip, and they also may be classified as complete or incomplete. The primary palate is anterior to the incisive foramen involving the alveolus, while the secondary palate is posterior to the incisive foramen involving the hard and soft palate. A complete cleft palate includes the primary and secondary palate, while an incomplete cleft palate includes only the secondary palate. So management of the problem. The orthodontist and oral surgeon play important roles in the management of children with cleft lip and their palate. Neonatals are first treated with NAM, or nasoalveolar molding, to closely approximate the distance between the clefted lip or alveolar segments in preparation for surgical closure. Some of these patients who present then in later years with a transverse deficiency of the maxilla then undergo phase 1 therapy with orthodontic appliances for expansion of the segments in early childhood to create a functional occlusion. As adolescents and late teens, cleft lip and palate patients finally receive comprehensive orthodontic and or surgical treatment to achieve greater aesthetic, skeletal, and dental harmony. Many of the orthodontic and surgical procedures that these patients undergo can impact the growth of the maxillofacial complex, and there have been numerous studies on this topic. So this is a little background on the surgical procedure. In 1962, Brower et al. Found that the pull of the soft tissue of the lip after closure in cleft lip and palate patients was associated with mid-face flattening and retrusion, so they advocated for early bone grafting of the cleft to allow for the maxilla to grow normally. So they generally perform this before the age of 4 and referred to it as primary alveolar bone grafting. However, later reports of studies found that primary bone grafting could actually hinder maxillary growth and cause malocclusion. Boyne and Sands in 1972 then introduced the concept of secondary alveolar bone grafting, which was essentially the same procedure but completed during the mixed dentition phase, which is we'll talk about that in the next paragraph. So the purpose of alveolar bone or cleft grafting is to replace the missing bone in the cleft site for continuity of the dental arch and to support the eruption and alignment of the adjacent permanent teeth, to provide support to the skeletal base and surrounding tissues, to provide support for the nasal alar cartilage, and to provide bone availability for future prosthetic implants or restorations. When performed after the age of 4, the procedure is called secondary alveolar bone grafting, but more specifically, this is between the ages of about 8 to 12, with the optimal timing between ages 8 to 11. This timing relates to the root development of the permanent maxillary canine, as well as the anticipated eruption of this tooth, as it should ideally erupt into the graft site within 1 year of the graft being placed. So the objectives of this scoping review are to assess the available literature regarding secondary alveolar bone grafting in cleft lip and palate patients, to determine the extent to which this procedure affects skeletal growth of the midface, notably the maxilla, and also to identify and summarize the relationship between the timing, dental, and chronologic, various methodologies, and patient and cleft characteristics associated with alveolar bone grafting to maxillary growth. So our PICO is for participants, subjects with cleft lip and alveolus, cleft lip and palate, or complete cleft palate from all ethnic backgrounds, presenting unilaterally or bilaterally without other structural or developmental abnormalities. Intervention includes alveolar bone or cleft grafting, which could be subdivided into primary or secondary alveolar bone grafting, in addition to osteoplasty or alveolar cleft augmentation or gingiva alveoloplasty or gingiva perioplasty. The intervention must have been completed between the ages of 0 and 16, during which time growth is occurring. Comparison, no comparison. In outcome assessed is the skeletal effect and relationship between the timing, various methodologies, and patient and cleft characteristics associated with alveolar bone grafting on maxillary growth. Exclusion and inclusion criteria. To be included in the full text review, studies must be in English or have English translation, have human subjects, have non-syndromic patients between ages of 0 and 16, and with clefts that include the alveolus and have had alveolar bone grafting procedure completed. To be considered for data extraction, studies must specifically have secondary alveolar bone grafting completed, a minimum follow-up post-treatment of 1 year. They must include some type of radiographic interpretation to measure results, and they must address maxillary skeletal development. Studies will be included if the participants are syndromic, if they have cleft lip, or if they have cleft lip only or an incomplete cleft palate, if the study is written in non-English with no translation available, if the intervention was done after the age of 16, if non-human subjects were used, if there's an incomplete sample description, or if full text cannot be retrieved. And then case studies, editorials, opinion articles, and review studies that meet the inclusion criteria will be excluded from consideration and instead used for discussion. The following databases were searched to identify potentially relevant literature: PubMed, Elsevier, Embase, and Dentistry and Oral Sciences, EBSCOhost. Combination of 3 keywords: cleft, lip, and palate, alveolar bone graft, and maxillary development. Their synonyms, stem variations, and relevant controlled vocabulary were composed into draft search strings and tested for precision and sensitivity, and searches for all databases were completed on February 7th and 8th of 2022. The results were exported into EndNote, and duplicates were removed using Brammer. 2 calibrated researchers will independently evaluate and sort the 1558 titles and abstracts that were found, following a detailed protocol and using the inclusion and exclusion criteria. Again, case studies, opinion articles, review articles will be placed into a separate category for discussion. Full text will be retrieved for any article that could not be determined for inclusion or exclusion based on the TIAB. They'll be further evaluated and sorted. A consensus will be reached through face-to-face discussions between the 2 reviewers or with the help of a 3rd reviewer. Full text will then be once again reviewed using the same criteria and protocol, and the full text articles which meet all inclusion criteria will be selected for data extraction. So here is our Prisma 2020, that's the template actually, but our Prisma diagram for how we will be sorting through these articles. Last year we had done up until that point, but throughout this year we finally did the data extraction. We found 15 studies that were included for this review. All studies were retrospective, and most, 12, utilized lateral cephalograms for analyzation of the treatment outcomes. SABG was performed using a block from the iliac crest for 8 studies, block from magnitubular symphysis for 1 study, and not specified for 6 studies. Majority of the studies found SABG has a high rate of success with good long-term prognosis. 1 literature review found no significant difference in maxillofacial growth between SABG and non-grafted individuals. 1 study found that the maxilla is shorter in length in cleft individuals than non-cleft. There was a lack of consensus on the growth effects of various treatment modalities of cleft individuals, and majority of studies found SABG performed before the eruption of the canine is the best time to allow, or for grafting to allow for the successful eruption of the canine. This correlates to between 9 to 11 years of age, or when the canine is within 1 year of eruption. In conclusion, We found that there is little to no disturbance on growth when comparing treatments in grafted and non-grafted cleft lip and palate individuals. There's a difference between cleft and non-cleft individuals regardless of whether the cleft is grafted. And also the benefits provided by performing this procedure on cleft individuals when considering dental development outweighs the negative sequelae on maxillary development. And then here are a few of my references. My full manuscript has all of the references as well as a more detailed written portion. Thank you. Bye.